We're getting started promptly because we have a large audience who is participating by webinar. We have a smaller than usual audience here, which seems to be because of spring break more than anything else, and I think it will be our last policy forum during spring break. So you can say you were there. Okay, so for those attending via the webinar, please feel free to send questions for the speakers at any time during the event. We will screen all of your questions for possible use in the Q&A period at the end. Let's see. Every 2 months or so, we have a policy forum like this, and we present the findings from our research, and often have outside speakers come in to discuss the policy implications. Today's speakers are going to present the early findings from the evaluation of the Social Security Administration's Accelerated Benefits Demonstration, commonly called AB. What a great acronym. As you likely know, Social Security Disability Insurance beneficiaries are entitled to Medicare after 24 months on the SSDI rolls, but some of them lack insurance during that Medicare waiting period, and they may have limited access to health care as a result. So SSA designed the Accelerated Benefits Demonstration to test whether early access to health care and related services would lead to improved health, increased employment, and reduced reliance on benefits among new SSDI beneficiaries who lack health insurance. SSA's prime contractor for AB is MDRC, one of our competitors, but this time we're a subcontractor to them. And today's first speaker will be my colleague, David Wittenberg, and he's a co-principal investigator for the demonstration. He's going to describe the recruitment of participants and participants' use of services and impacts during the first 6 months of the project. And then we are also pleased to be joined by Charles Michaelopoulos, who came in all the way from West Coast for this, from MDRC. He's also a co-principal investigator, and he's going to discuss the impacts through the first year of the project and also the cost of service use. We're also pleased to be joined by Bob Weathers from Social Security Administration. He's the co-project officer for the demonstration, and he's going to discuss the policy implications of the findings. So thank everybody for coming, and let's get started. Dave?
Okay, I guess the first thing I wanted to do before I begin is to start with a few acknowledgments, because in a project this size, it really takes a village to get things done. And at the outset, I first and foremost want to thank Chris Solanskis, who is probably on the phone, and his team at Social Security Administration. Chris is the project officer on the project from the start, and he successfully navigated the project through several changes. The AB project looks very different now than from what it did at the initial design phase. Chris was heavily involved in that, and he led a team at SSA that really helped improve the final findings in the evaluation report. I'd also like to acknowledge David Butler, who is our fearless project director from MDRC, and David had the unenviable task of managing a very complex implementation and evaluation design, and he had to do so within a very tight time frame, within five years, and we're happy to say that we finished the project on time, in large part due to his tremendous coordination efforts. And finally, I'd like to thank Lisa Schwartz and her survey colleagues here at Mathematica. Lisa successfully led the survey teams who actually exceeded response rate targets for many of the data that both Chuck and I will be describing today. So as you look at my title slide, you'll see the goal of my talk is really to discuss the recruitment process and impact findings after 1 year. And I'm kind of the precursor to Chuck's eventual presentation, where Chuck will describe the 1-year impacts. The key takeaway from, I think, both my presentation and Chuck's presentation is that while we summarize the accelerated benefit findings in a final report, the findings are still very early in the demo at the 12-month mark. There are some promising impacts, especially on healthcare usage and unmet medical needs. However, it's a very expensive demonstration, and a longer follow-up period is really necessary for a full assessment of impacts that could not be covered in this report. For example, the eventual impacts on Medicare spending. So the motivation for this project, as Dave Stapleton had mentioned, the motivation for this project comes from the fact that new Social Security disability insurance beneficiaries must go through a waiting period, typically called the 24-month waiting period, before that they can qualify for health care coverage through Medicare. The problem is during this period that the health status of beneficiaries could deteriorate. This could lead to further dependency on the SSDI program, and it could also lead to longer-term costs for the Medicare program if people's health problems are not dealt with early enough in the process. So when SSA funded the Accelerated Benefit Demonstration, even though the design changed, the questions that it was looking to answer did not change. And the key questions that were addressed in our one-year follow-up report was, can providing AB healthcare benefits and other supports, and I'll get to what those other supports are, but they're enhanced employment and behavioral and medical case management supports, lead to an increase in the use of healthcare, improve health outcomes, and increase employment. And these are really short-term outcomes that are covered in our report. There's also long-term outcomes, such as what is the impact of accelerated benefits on other programs, including Medicaid, Medicare, and also ultimately Social Security disability benefits. The study team the study was conceived and funded by the Social Security Administration. MDRC and Mathematica conducted the evaluation. The health benefits were administered by a company called POMCO. POMCO was selected because it had health coverage across the nation. It's also notable that POMCO was MDRC's health administrator, so there was sort of a natural link there. And if anybody's been to a football game, POMCO also sponsors KISS camps. So just a little side note on POMCO. The services, the extra services that I just had mentioned, that we call AB Plus, were provided by a group called Care Guide and Transcend, who coordinated to provide the behavioral health, the medical case management, and the employment counseling services. The demonstration tests two specific interventions. The first intervention is what we call AB, or the health plan only. And the health plan was designed by a team of experts. And essentially the main goal in designing the health plan was to make it accessible and to get people earlier access to health care and to open access so that they could use it for early intervention services that might ultimately lead to independent outcomes such as employment. The AB health plan is characterized by an expansive network, generous coverage, and very low co-payments. In comparison to the Medicare plan, which is available to disability insurance beneficiaries, AB has lower co-payments, provided greater reimbursement to providers, and paid for some items like durable equipment and dental care. The one big difference between the AB health plan and Medicare is the AB health plan had a $100,000 cap, which was instituted to ensure the project stayed within the specific budget allocated by FSA. The second intervention is something that we call AB Plus. This is the same health plan plus other types of supports. And these are the types of supports that the technical working group that helped assist in putting together the design thought might be necessary in stabilizing people medically and moving them into employment and independent living. And there were three components of AB Plus, and I'm going to discuss those in much more detail later in my talk, but in brief, they were the Progressive Goal Attainment Program, or PGAP, which was a behavioral modification program that's really designed to reduce someone's perceptions of their own disability so they can move beyond that and move into activities such as work. Employment and benefits counseling, so people have a better understanding of the impact of work on the benefits, as well as some basic employment support such as resume writing. And medical case management, which was really designed for basic medical stabilization. The sample sizes of the three groups included an unbalanced sample. And one of the things that you'll notice immediately is that the sample size of the AB and the AB Plus group differed from the control group. The final sample size for AB was 400 cases. The final sample size for AB Plus was 611 cases. And the final sample size for the control group was 983 cases. there's a logical question of how we got there. And part of the response is that during the intervention, and this is a key part of the story today, we had to stop recruitment because healthcare expenditures were much higher than SSA and the team had projected at the time. So we changed the random assignment algorithm. So in the second half of the study, we only recruited AB and control group members. The original design was really looking to have an even sample of AB plus and control group members for subgroup analysis. But when the healthcare expenditures were larger than expected, we had to change that design. Despite those changes, we were still able to assess the effects of AB and AB plus and how those effects differed from the control group. And Chuck will describe those in more detail in his presentation. In terms of how we got the sample, we used a two-step process. The first step process was to take a look at Social Security Administrative records that SSA staff sent the evaluation team. And the first general criteria were that beneficiaries were selected between the ages of 18 to 54 across the 53 sites. And the reason why we used that age category is that we wanted to select a group of beneficiaries that were far enough away from retirement that they had the opportunity to return to work and wouldn't immediately go into retirement after the demonstration ended. The 53 sites were selected because those were the largest metropolitan areas that included the largest concentration of SSDI beneficiaries that would be needed to meet our sample size targets of 2,000 beneficiaries. The second criteria, and this is a really important one for understanding our sample, is that they had to have at least 18 months until they were eligible for Medicare waiting period. We did this so there would be a minimum dosage of healthcare services available to all sample members. Finally, there were some other administrative requirements, such as that the beneficiaries couldn't be receiving supplemental security income, which is often tied to Medicaid. This sample was then taken by the survey team, and they used what I'll call a short survey screener. I think it was approximately 18 questions, where they verified the insurance status of beneficiaries. And the eligible beneficiaries were the ones who reported no source of health insurance. And the types of health insurance that we screened on were, did you have Medicaid? Did you have Medicare? Did you have COBRA? Did your spouse have insurance? And people that continually responded no, they didn't have any of those, were counted as uninsured and put into a pool of uninsured beneficiaries. One of the very interesting things right from the start of the demonstration was the strong interest in the sample that was screened as uninsured. Basically, if you offered an uninsured population health insurance, they take it. Now, this may sound obvious now, but it wasn't obvious when we were designing it that the take-up rate would be so high. But 99% of the people that met these uninsurance criteria actually wound up participating or wound up consenting to be randomly assigned to the demonstration. I think it also gives you some insights into the types of healthcare needs that our population is looking at. So what were the characteristics of the insured and the uninsured beneficiaries? First, most people had health insurance, and 88% of the beneficiaries screened out from eligibility. So 88% of our original population was not eligible for the demonstration. This was kind of a surprise, but follow-up studies by Riley and Livermore that were conducted just around the same time of our recruiting also confirmed very similar findings that 80 to 80% of people in the waiting period had health insurance. And the most common source of health insurance was private health insurance, either through a spouse or through their own personal coverage. The uninsurance rate varied quite a bit across sites. The overall rate was 12%, and across the 53 sites, the rates ranged from 4% to 53%. In general, the highest uninsurance rates were in the southwestern sites. Oklahoma City, Houston, and several areas of Texas had uninsurance rates above 18%. The lowest rates were in the northeast, northern, and western sites, which were Buffalo, Boston, and multiple sites in California. And as a matter of fact, the uninsurance rates were so low in Buffalo that we actually stopped recruiting there. They were only 4%. But this uninsurance rate also gives you a sense of what the distribution of the population was that participated. The uninsurance rate patterns that we see here are generally consistent with the uninsurance rate patterns in the general population as stated by the Kaiser Foundation. So, as I mentioned earlier, the AB sample really represents a unique segment, not only of the population, but even of new SSDI beneficiaries. These were cases that were faster to adjudicate due to the requirements that people have at least 18 months of Medicare eligibility. When you apply for SSDI, many people have to go through the appeals process. And when they successfully go through the appeals process, their date of onset is backdated, and they are often eligible, or I should say some are eligible for Medicare right away. Our sample for AB were people that went through the initial determination process and were almost immediately put on the rolls. They were quicker to adjudicate, so that probably means that they met the medical listings criteria for SSA. They were relatively younger due to the age cutoff at 55, approximately half are under age 50. And they really had a diverse mix of impairments. Mental disorders represented 22% of our population. Nervous system was 17%. Musculoskeletal represents 19%. Circulatory represents 12%. And neoplasm impairments represent 8%. And other represents 22%. And this is notable in terms of thinking about the health plan because it gives you some insights into the types of services that they're eventually going to use in the demonstration. There's a very differing need for the types of specific health services. And this is going to be a big theme later on in the usage of service findings. The characteristics at baseline. These characteristics generally demonstrate a need for healthcare services and a potential demand for other types of services. At baseline, 35% of our sample was considered obese, which meant which is defined as a body mass index of 30 or higher. 94% had difficulty with an instrumental activity of daily living, such as walking. This finding is consistent with the requirements to qualify for Social Security disability. Self-reported health was poor among 47% of the population, so almost half of the population reported poor health. The 64% of the population was insured for more than was last insured more than 6 months ago. So this was not just a newly uninsured population that we're dealing with. Over half had been uninsured for several months. 70% reported an unmet medical needs, such as not being able to go to a doctor, and only 5% were working. So, in short, they're in poor health, have been uninsured for a long period of time. So this is a good population to test a health insurance or a health plan intervention with, or as good a population as possibly you can come up with. So early in the study, we conducted a 6-month survey to assess the use and satisfaction with services with a subpopulation of beneficiaries. And we used a survey, a subsample of control and treatment group members to assess, for satisfaction we used treatment group members. And what we found was early on, most of the people had used the health plan, over 80%, and 90% reported being very satisfied with coverage. So not only were they immediately consenting to work for random assignment, once they were in the demonstration, they were immediately using the health plan. The impact findings, which Chuck is going to go into in a lot more detail, at 6 months suggested that the impacts were going in the direction that we might expect based on the initial questions I put up on the initial slide, which was we saw some increases in health care and some reduction in unmet needs. And the final part of the story from the 6-month analysis, which was a key part that our technical working group wanted us to look at, is what's happening to the control group? Are we getting a good test of the health intervention? And is the control group cycling on and off health insurance? And what we found was the majority of the control group remained uninsured based on our battery of insurance questions. 76% still did not have health insurance at 6 months. But despite this issue, they were still using some health insurance. 71%, or not health insurance, were using some type of regular source of care. In terms of the health plan usage, at 12 months, and these are data based on claims data from our management information system, most AD and AD plus participants used the health plan, and they generally used it very quickly within the first 6 months. In fact, claims tended to spike during those first 6 months and leveled off. The most common usage was for physician visits, diagnostic testings, and prescription drug coverage. Over 80% of the sample used those things. somewhat surprisingly, only 20% use dental, even though this isn't covered by Medicare. And in some of our follow-up process interviews with the staff, one of the reasons cited for the low dental care use was the fact that people were addressing more immediate pressing needs first, and they weren't using dental right away. In terms of cost, costs were driven by a few participants. 12% had payments of $50,000. And in terms of our overall accelerated benefits budget, this 12% represented 53% of health claims costs. So there's a huge skew in health claims usage by a small number of participants. And this is consistent with health claim usage in other sources like Medicare. The higher costs, and maybe this is not surprising, but were among beneficiaries who reported poor health at baseline and those who had neoplasms, which is cancer. And so the end-of-life care was especially costly. 4% of our sample reached the $100,000 cap. So you can see that cap was really important in maintaining costs for a demonstration. The AAD participant claims were also relatively costly to other groups. The best comparison group that we have is Medicare claims for other SSDI beneficiaries. As I mentioned, the AD group is a unique segment, so you have to take that into account. But in general, the spending on AD during this first year was nearly twice as high as what it was on Medicare, approximately $19,000 versus $11,000. So a very costly health plan. This next flow chart shows the AD Plus services and how they were delivered. As noted, the framework was established to meet the diverse needs of participants. At the outset, after a person activates their health plan, they're immediately contacted by a coach from CareGuide, and all of the AD Plus members are contacted by the coach for a 1-hour intake assessment and introduction into the service. And they were, this coach, which you see in this next box down here, also administered the PGAP component of the intervention. And people were immediately referred into PGAP unless there was a medical reason that they thought that they couldn't participate, like if there was a medical stabilization issue or they had an end-of-life type of situation. There was a nurse who administered the MCM, or the medical case management component of the intervention. And generally, participants were referred to MCM if they had a near-term issue, or particularly later on in the demonstration if they had a mental health issue that needed stabilization. And there was one nurse that dealt specifically with mental health issues. And finally, there was a counselor, and this counselor was from Transcend, that administered both, one counselor administered employment support such as resume writing and referrals to local employment supports. And there was a benefits counselor who helped administer the actual benefits counseling support of the impact of work on benefits. In terms of AD Plus usage, this slide provides a snapshot of the overall usage across the major components. And this slide only shows the actual time that the nurses, coaches, and benefits counselors spent with the client. It doesn't include preparation time. It doesn't include missed phone call time. It doesn't include coordination. In total, 66% participated in one of the following services, PGAP, EBC, or medical case management. This 66% doesn't account for the fact that actually 84% conducted the initial intake. It's just 66% eventually used one of these core services. 36% participating in PGAP across the caseload, and on average there was 1.8 hours used per person. 35% used employment and benefits counseling with an average of 0.9 hours, and 42% used medical case management with an average of 0.4 hours. In information not shown in the slide, the participation really varied across services, which in part reflects the diversity of the needs of the population. For the PGAP participants, in general, they tended to have more education relative to other participants. The employment and benefits counseling participants tended to be in better health, and those that were in used medical case management tended to be in poor health, also tended to have cancer. So in terms of the lessons that we can take from here, the upside is the AD Plus staff were able to contact a large portion of the caseload and actually provide some types of services. 66% of the AD Plus participants received services. So this is a fairly high percentage of people receiving services. And the staff also felt like they can engage this population with facts about benefits counseling. The downside is you look at the number of hours used, is the intensity was very low. It's hard to keep participants engaged in these services. And often staff had to make multiple contacts in delivering these services. So in terms of the summary, as I turn it over to Chuck, eligible beneficiaries at baseline had special needs for health care coverage, and that affected the use of services. And I think it's also important to consider who the eligible population is, because it tells you something about the generalizability of the findings. We're dealing with a very select portion of SSDI beneficiaries. But from the 6 to 12 month mark, we generally have promising impacts on health service use, but there's substantial spending on AB health claims, which is higher than we see in other plans for people with disabilities. And most AB Plus participants used at least one AB Plus services, but intensity was low. So, Chuck?
Thanks, Dave. So with that background on what the programs were, I'm going to talk a little bit about what the impacts were at the end of the first year and during the first year after people entered the study. Just talk a little bit about what we expected to find. Some of this will be kind of obvious when you think about it for a few minutes, but first thing was that we're providing individuals who weren't insured with health care benefits. And so, of course, we expected them to take advantage of that by increasing the amount of health care they used. If they used, more health care and had their unmet needs reduced and were using, a greater proportion of the care they were supposed to get, the hope was that this would lead to better health outcomes and better functioning. So you see fewer people with, problems with activities of daily living, but see improved health and functioning. That then might in turn lead to, really the ultimate hope, increases in work and employment. We think in the first year we were unlikely to see this last part, increases in employment, in part because it would take a while for all of the stuff to filter down to that, but also in part because during that first year incentives are such that individuals might not want to work too much. Now, although this first part of the slide seems kind of obvious, turns out that the literature on this question isn't really, super strong. There's a fair amount of non-experimental research on the effects of health insurance and whether that increases healthcare use and improves health, but it's a little bit controversial about what those effects are because it's all based on non-experimental, evidence where, for example, people without insurance are compared to people with insurance. So this is the first random assignment study of providing healthcare benefits and give some really solid evidence. On the AD Plus side, the idea was that a couple of things might happen. First, medical case management might affect the kinds of health care that people were using. As Dave mentioned, the nurses doing medical case management were especially likely to work with people who are depressed or have other mental health issues. So you might see an increase in mental health care use because of that. They also got referrals for people who had immediate needs like terminal illnesses or critical illnesses that really needed some immediate care. So you might see some changes in the kinds of health care used on that side. The other two types of services were more directly about helping people look for work and preparing them to look for work. So the idea was that we might see some increases in work preparation and, ultimately improvements and increases in employment. To investigate the effects of AD on these, we used primarily a survey that was administered about a year after random assignment, and we were just talking about how there was about a 90% response rate for the survey, one of the highest probably in any study I've ever been involved with. Lisa Schwartz gets a lot of the credit for that from Mathematica. One of the results I'll show you will be based on administrative data from FSA, but the others will be based on this survey. So what did we find? The first slide, going through that logic that I just talked about, let's talk first about whether AB increased healthcare use. And this slide shows you can't actually see the middle bars on them. I can see them here. You can see them if you're looking at a piece of paper. But there should be three bars, four outcomes, three sets of bars. One bar shows the outcome level for the AB plus group on the leftmost one. The middle bar, which isn't showing up on the projector here, shows the outcome for the AB group. And the rightmost bar shows the outcome for the control group. Fortunately, in this case, the differences between the AB and the AB plus group are really small, so just think about the AB group as having the same levels as the AB plus group, and you'll be in good shape. For this slide, the vertical axis just shows the percentage of people who, had the particular outcome, and you can see four outcomes here. The general story here is that, yes, AB and AB plus, the AB health benefits did increase the amount of health care that people were using. And really increased it across a whole wide range of different types of health care. It increased, for example, the percentage of people who had a regular source of care from about 70% to about 90%, 30% of the control group to about 90% of the AB and the AB plus groups. So an increase in there. Also, you see really the biggest impact is on things like diagnostic care. You see increases in the use of specialty care. Increases really, as I said, across a whole wide range of outcomes. One thing that kind of surprised us at first was how many control group members said they had a regular source of care, about 75% at the 6-month point. But it turns out that the literature is fairly consistent with this, that people with a chronic condition, even when they're uninsured, do tend to have a regular source of care, and the uninsured use about 70% of the care that people with insurance use. So it was sort of a naive expectation to think that the control group wouldn't use any care at all. Moving on to the second outcome on the slide, you see also a similar percentage increase in the proportion of people who said they regularly took medications. Again, from about 80 to about 90%, 80% of the control group to about 90% of the AB and the AB plus group. So an increase there. You also see an increase in the proportion of people who underwent surgery. This went along with an increase in the proportion who had been hospitalized, over a similar amount. This one was actually a little bit bigger, maybe about 10 to 15 percentage points, from about 20 to 25% of the control group to close to 35 to 40% of the AB and the AB plus group. And this, I think, was an indication that one of the things that it may be possible for people without insurance to have a primary care doctor and go for doctor visits, but surgery is something that's pretty expensive, and this is one of the things where AB had some of its biggest effect. The last outcome shown here is whether people visited the emergency room, and there was no significant impact on emergency room visit at 12 months. The incentives here kind of go in both directions in the sense that accelerated benefits did pay for, except for a copayment, pay for emergency room use, so there was an incentive to use emergency room care. On the other hand, it was also paying for visits to primary care doctors and regular preventive care, and we saw an increase in that, so that might have reduced the ER use, and apparently the two kind of offset each other, and we don't see an impact of that. Moving on to the next slide, the next step in the logic model was, well, not just whether it was increasing the amount of health care, but was it sort of increasing the intensity of health care as well? And the way we measured that was asking people whether they still had unmet medical needs, even after, unmet medical needs, given the amount of care that they were using. And the story here is that you see much bigger reductions, much bigger effects because of the AB health benefits on unmet medical needs than you did on the healthcare use. And here again on this slide, it's not quite the same, but the levels for the AB and the AB plus groups here again were pretty similar. There wasn't much of a difference between AB and AB plus, so the medical case management and the other AB plus services didn't do much. If you can't see the middle slide, just think of it as the same height as the leftmost slide. Just starting on the left part of the figure, we first asked people whether they had any unmet medical needs for any reason. It could be due to cost, it could be because they just couldn't find a way to get to the doctor, just whether there was any unmet medical need at all. And you can see a pretty substantial reduction from about close to 70% of the control group saying they had any unmet medical need to about 50% of the AB plus group, so about a 20 percentage point reduction. When we focus that on unmet needs due to cost, which is shown in the second set of bars, you see a much bigger impact. It really cut that in half from about 60 to 70% of the control group to 25 to 30% of the AB and the AB plus groups. So this makes sense. If somebody wasn't going to the doctor because they didn't have transportation, or they just for whatever reason they were depressed and they couldn't get out of the house to see a doctor, AB wasn't directly helping with that. If they weren't seeing a doctor because of cost, the AB health benefits were supposed to affect that, and so you see much bigger reduction in unmet needs, specifically due to cost. Moving to the third slide, you see even bigger reductions in any unmet needs that are related to medications. And here it's about 70 to 80% of the control group said they had some unmet need due to medications. This might be taking less of a medication, or it might be not getting medications at all, down to about 35 to 40% of the AB and the AB plus group. So again, cut in half the proportion of people who said they had any unmet need for medications. And I think this also is consistent with literature where you definitely see get the sense that one of the places where people first cut back in their medical care is on medications, maybe cutting pills in half and taking half their medication, half of their dose at a time, and that sort of thing, and trying to make it stretch. And so you see a pretty big decrease here. One of the things that was also striking to us, though, I'd have to say, in these three sets of outcomes related to any unmet needs, is how many AD folks said they still had unmet needs. So even though we were providing them with pretty generous health care benefits that had, by most standards, pretty low co-payments, 25% of the AD and the AD plus groups said they had an unmet medical need due to cost. So it's an indication that for a group like this, about 40% of our sample had an income of less than $20,000 a year. Even asking them to pay $12 for a doctor visit or $5 to $15 for a medication could discourage them from receiving that care. The last set of outcomes on this is the proportion of people who had out-of-pocket expenditures of less than $1,000. And not surprisingly, AD increased this percentage because it was providing health benefits. Folks in the AD and the AD plus groups were spending less out of pocket. If you're looking at the slide that I'm looking at and you can't see the middle bar, this is one place where it does make a difference because fewer AD members reported spending less than more AD members reported spending less than $1,000 on health care out of pocket than did AD plus members. So it actually reduced out-of-pocket expenditures even more for the AD group than for the AD plus group. And that's probably due to just a series of very small effects on healthcare use between the AD and the AD plus groups that has led the AD plus group to spend about $1,000 to $1,500 more on healthcare use, in total during that period. Moving to the next slide. So the next question was, now that we see that AD and AD plus increased healthcare use and reduced medical needs, did it improve health and functioning? And the answer here is yes, it did improve health and functioning, although the impacts aren't as big, and as consistent and as solid as they are on the healthcare use. And here there are four outcomes. The first outcome shown here is the proportion of people who just said in a very simple question that their health was good or better, and good or better is a good thing. And it did go up from about 20% of the control group to about 30 to 35% of the AD and the AD plus group. So there were significant effects on that. It seems like a kind of a naive question, but turns out it's a simple question that's a really strong predictor of the amount of health care that people are going to use in the future, and people think of it as a good indicator, even though it's self-reported of people's overall health. The next two outcomes shown here are summary scores from the SS-36, which was administered in the survey, physical functioning scale and a mental functioning scale. And here, actually, the stars, I hadn't mentioned the stars. Stars were on these slides to show where impacts were statistically significant. And here, there was actually a mistake on the slide. There should be a star over the physical functioning scale because the AD plus group did have significantly better physical functioning on the summary scale than the AD group. And both the AD and the AD plus groups had significantly better mental functioning as well. We were a little bit surprised that the impact on mental functioning was bigger than the impact on physical functioning, because only about 20% of folks in the study had as their primary impairment the mental health outcome. And if you look at the amount of mental health care that was used, only about 25% used mental health services. So this might indicate that just providing people with health benefits, it just by itself has effects on people's stress levels and feelings of well-being that show up in the mental functioning scale. Underlying the SF-36 are 8 subscales, and you see impacts of both AD and AD plus on a majority of those subscales. And the final result on this slide is the proportion of people who died after random assignment in that first year. And here, there are no stars. There weren't significant impacts. We showed it just, in the interest of completeness. There are slightly higher rates of death in the AD and the AD plus groups, but they weren't, statistically significantly higher. I should mention at this point, too, that obviously folks who died in the first year didn't respond to the survey. And so all the results from the survey are for the folks who could respond to a we did some sensitivity checks to see, would the results have looked any different if we had, inferred some things about those folks who, probably had worse health and things like that. But because the proportion of people who died was pretty small and was similar across the three groups, all of the results I'm presenting here, would look pretty similar, even after the sensitivity check. So the follow-up question was, given the increases in healthcare use and the improved health, and given the AD Plus services, was there any indication that AD and AD Plus got people to prepare more for work, and any indication that they were working more? And there are three outcomes here on that, and one outcome related to difficulty meeting living needs that I'll talk about. The first set of bars here is just an overall measure of whether people reported having received any employment services. And these are intended to be employment services that, were outside of the AD program. So this wasn't talking to the Employment and Benefits Counselor through AD Plus, but other programs. And here, this is one slide we're not being able to see the AD group. If you're just looking at what I'm looking at is problematic, because there are significant differences here between AD and AD Plus. AD Plus doubled compared to the AD group and the control group, the proportion of people who received employment services from about 5% of the control in the AD groups to about 10% of the AD Plus group. So it did have a significant effect on whether people received employment services. There was, this effect was concentrated especially in people reporting that they were using the Ticket to Work program, so some indication that the Ticket program is an important resource for folks who are looking for work. Moving to the second set of bars, so people were preparing for work, they were using the Ticket program, they were using, both rehab services and that sort of thing, so they actually looked for work in the year after random assignment. And here again, there was a significant impact of AD Plus compared to the AD group and compared to the control group. More AD Plusers, looked for work, and again, the impact was about 5 percentage points, an increase from about 10 to 15% of the AD and control groups to about 15 to 20% of the AD Plus group. So about a 5 percentage point increase in looking for work and receiving employment services. The third set of bars shows, however, that this didn't yet in the first year translate into significant effects on actually working. So similar rates of about 10% in all three groups are looking for work. So something promising, people are starting to prepare, starting to look for work, but in the first year it didn't show up in more employment. The final set of bars shows what effect AD had on whether people had difficulty meeting living needs. And this was things like being able to pay their rent or mortgage, or having utilities cut off, or telephone service cut off, and that sort of thing. And the idea here was that by substantially cutting back on how much people were spending out of pocket on health care, that meant that they had more money to use for other things in their lives, and that may translate, especially for lower income families, into being able to pay bills and pay for necessities. And here again, we do see some significant impacts on those outcomes. So folks in both the AD and the AD Plus groups were significantly less likely to report that they had difficulty meeting living needs. So just another outcome that another side effect of being able to provide health benefits. Okay, so what did all this cost? Quite a bit, it turns out, especially for healthcare. This slide shows at the top the cost of the AD health plan, mostly for paid claims and for administrative costs, and then the bottom half shows the cost of AD Plus services. The two columns show the cost for, when the average is across all program group members, all 100%, even if they didn't use the service. And the second column shows the average when it's just averaged among those who used it. So, for example, since, almost everybody in the AD and the AD Plus groups used the AD health plan, the cost for a person who used the plan is only a little bit higher than the cost per program group member. That's not the case when we get down further on the slide. So starting at the top of the slide, the AD health plan costs about $31,000 per person over the full intervention period. This is an average of about 21 months, per person. About $31,000. It's important, though, to remember when looking at this, that this is a gross cost number. This is what the Social Security Administration paid for health benefits and for administering the health benefits for folks. As you saw on the earlier slides, the control group used quite a bit of care as well. We don't know the cost of that care, but the net cost to society of providing AD is going to be substantially less than this $31,000, which I'm not sure how much less. Turning to the bottom half of the slide, AD Plus services on average cost about $3,300 per person, and about $3,700 per person who used the AD Plus services. That 3,300 is distributed, not completely equally across the different types of services. About half of it was spent on employment and benefits counseling, and I think it turns out that as Dave's slide earlier pointed out, employment and benefits counseling wasn't the thing that people necessarily used the most, but employment and benefits counselors were paid better than the coaches who were doing TGAP, and that was part of the reason that cost a little bit more. TGAP accounted for about a quarter of the costs of AD Plus services, and then the medical case management and the ongoing coordination made up the rest, so about $3,000. In terms of thinking about, is this a cost-effective program, obviously in the first year it's not, because to be cost-effective, you have to see some increases in employment and reduces in SSDI benefits. The question is down the road, will it have those effects? And the early impacts we're seeing on employment preparation and employment services, hold out the hope that maybe that $3,000 can be recouped down the road. But we'll see. So just a quick summary. The impacts look really promising. We think they're really important because, as I said, this is the first random assignment study of healthcare benefits, especially for this very high-needs group. But we did see substantial increases in healthcare use and substantial reductions in unmet medical needs, some improvements of health that were, I think, pretty consistent, but just smaller in magnitude. And then some increased preparation for work and job search that we're keeping our fingers crossed will translate into longer-term effects on unemployment, but we're still cautious. It's still early. This was done a year into the program, and the individuals were eligible for AD for anywhere from 15 to 24 months, so it could be only halfway through the intervention for some folks. AD health benefits were expensive, even though we don't know the corresponding cost for control group members. It was pretty clear that a lot more was spent on AD health benefits than for the control group. And then you are going to have to see long-term reductions in SSDI benefits and in Medicare and Medicaid use if the federal and state governments are going to recoup this. Probably, I won't say whether FSA has chances of recouping it, but the hope is that the improved health and functioning and increased healthcare use in the short term will at least translate into reductions in Medicare or Medicaid use down the road that could make it more cost-effective. And with that, I'll turn it over to Bob Weathers.
Good afternoon. I'd like to begin by acknowledging David Butler and the MDRC team, Dave Wittenberg, Lisa Schwartz, and the MPR team, and Chris Lanskus and Michelle Stegman from SSA on making the AD project a real success. I'm Bob Weathers. I'm from the Social Security Administration's Office of Program Development Research, and I'll be talking about the policy and research implications from the AD demonstration project. We expect that the AD project is going to provide us with data that's going to be very useful in informing our policy and research over the next several years. Next slide. So to begin, I'll talk about some policy implications. I'll use the rule of threes here and provide three examples. The first are policy implications for the healthcare reform legislation called the Affordable Care Act. The second will be lessons for our work incentives planning and assistance grantees who provide employment and benefits counseling services to our beneficiaries. And then the third will be lessons for our Supplemental Security Income TANF project, or Temporary Assistance to Needy Families project, that we're currently doing jointly with the ACF at Health and Human Services. They might call it the TANF SSI project. We call it the SSI TANF project. So the lessons for healthcare reform legislation, and in particular, are also known as the Affordable Care Act. Our data from the initial survey interview of AD beneficiaries showed that 75% of beneficiaries had household income levels that were below 400% of the federal poverty line. The Affordable Care Act includes subsidies for individuals to purchase health care through health exchanges that for people who have household incomes in that range. So we take from this data from accelerated benefits that the healthcare reform legislation is going to reach and help quite a few of our beneficiaries coming onto the program. About 75%, as I said, would be eligible for subsidies. And then another 30% had household incomes below 133% of the poverty line, which would make them eligible for Medicaid under the healthcare reform legislation. We also saw from Chuck's presentation that many of the beneficiaries coming onto our program, they have unmet medical needs, and we believe that expanding access to healthcare insurance or healthcare through the Affordable Care Act will really reach a great number of our beneficiaries and provide some help with them. The other lesson for the Affordable Care Act is the need to focus on prevention. Dave showed you a slide that showed that about 45% of beneficiaries coming onto the program report to us that they have a body mass index that would make them obese. And this would put them at risk of other healthcare complications, including diabetes and other obesity-related diseases. And then, of course, with diabetes, if you don't monitor your blood sugar levels, that can create a whole host of new healthcare problems for an individual. And focusing on preventative services early can really have a big impact on saving some money in terms of Medicare and possibly reducing dependence on DI benefits in the long run. We also saw that there was, in our data in the final report, that there is a lack of needed preventative health care for the population, so that really identified a need here, and focusing on preventative health care services for our population is going to be really important, and we hope we can leverage some of the expanded access to health care under the Affordable Care Act to help our beneficiaries. The third is how the Affordable Care Act is going to interact with Medicare benefits for the DI program. What we might see is that expanded access to health care through the Affordable Care Act might reduce Medicare and Medicaid costs during the 24-month waiting period, and Medicare costs after the 24-month waiting period, if that earlier access to health care leads to fewer health complications in the long run. It may also reduce reliance on SSDI benefits if it helps individuals address their health care needs, improve their health, and improve the chances that they return to work at substantial gainful activity level. The second lesson is lessons for our work incentive planning and assistance grantees. One of the subcontractors from DRC, Transcend, developed really innovative ways to administer employment and benefits counseling service effectively by telephone. And what we were particularly impressed with the one-year findings was that AEB employment-related service impacts, that there were AEB plus employment-related service impacts within the first year of enrollment into the project. And these are the sort of effects that the employment and benefits counseling services were supposed to achieve. So we're really impressed by that. And we have a number of examples in the final report, which, by the way, will be posted on our website next week, that show some of the innovative practices that Transcend used to help beneficiaries, and we believe that some of these services could benefit the work incentive planning and assistance grantees so that they can more effectively provide services to our beneficiaries. The third are lessons for our TANF SSI population. SSA and HHS are exploring programs that will allow us to better serve individuals who are receiving both TANF and supplemental security income payments. However, the utilization results from the AB demo indicate that one of the programs that we were looking at early on, the Progressive Goal Attainment Program, is unlikely to be completed by the TANF SSI population. What we found in the report was that a small percentage of beneficiaries who had characteristics that looked very similar to our SSI TANF population used the PGAP program, and a smaller percentage completed the first 4 modules, which was the amount of TGAP that it's completed would have an impact on behavior. So when we looked at the findings from the final report, we came to 2 conclusions. Either one, TGAP would have to be restructured in order to better serve the SSI TANF project, or we could look at other programs that might be more effective in reaching our SSI TANF population. So next I'm going to turn to our SSA research that we plan to conduct in the next several years with the AB demonstration project data. And here I'm going to depart from the rule of 3 because I'm very interested in research and there are a lot of things that we can do. So I'm going to talk about 4 different things. First, talk about a little bit more work we're planning on doing that looks at the AB effects on health and mortality. Second, I'll talk about how we're going to use the data to examine the impacts of expanding health care coverage on Medicare participation and expenditures both during the 24-month waiting period and then after the 24-month Medicare waiting period. I'll talk a little bit about our research that we plan to look at how the AB project affected Medicare expenditures after the 24-month waiting period, and then talk about our research that we're going to plan on doing to look at whether there are impacts on employment and benefits paid to beneficiaries. So to begin, I'll talk about the research we're going to look at to study health and mortality. The first year report focused on mean impacts for those SF-36 measures that Chuck presented. And the SF-36 actually produces a score that goes from 0 to 100, 0 being very, very, very poor health, 100 being the highest health that you can report. But there's a distribution there, and for the population it's normed so that 50 is the mean for the population. But the mean impacts can miss important difference, and you might feel very differently about a program that has a small impact on everybody compared to a program that has a very large impact on a smaller group of people. So what we plan on doing is examining the cumulative distribution of the SF-36 scores between the groups that received the AB health package and the control group to see whether there are differences in the health distribution of the impact of AB on health. What we found preliminarily is that there's a very little impact on the tail, so people that are in excellent health, there's a very little impact on health of the AB package on health, and people who are at the very low end of the distribution, there's a very little impact. We believe that this is going to provide additional information to the results that will supplement the results that Chuck presented earlier. Chuck also showed short-term impacts on mortality, and we found no effect for AB health groups, but in the short run, but there's an indication of reduced mortality in the long run for the AB group. For the AB plus group, the findings aren't as promising as for the AB group. Second item we want to look at are reductions in Medicaid expenditures during the 24-month waiting period. Beneficiaries who didn't have health insurance at the beginning certainly can qualify for Medicaid during the waiting period if their income and resources fall to a level that would make them eligible for Medicaid. And Stacy Dale and Jim Verdier from Mathematica did an outstanding paper that noted that eliminating the 24-month Medicare waiting period may substantially reduce Medicaid costs and provide much needed relief to states. We're obtaining data from the Centers for Medicare and Medicaid Services on Medicaid enrollment during the waiting period to provide further information on this subject. And reductions in Medicaid costs during the 24-month waiting period could substantially offset the costs that Chuck showed of providing AB benefits to beneficiaries. The third slide is a typo here. This is reduction in Medicare expenditures, so it shouldn't have edited here. The other item we wanted to look at was earlier access to needed health services that improve health may substantially reduce Medicare utilization after the 24-month waiting period. So the basic idea here is that if people receive the services early, are able to address their health conditions, that when they transition on to Medicare, there might be a reduced demand for Medicare and lower Medicare expenditures. And we're obtaining data from the Centers for Medicare and Medicaid Services on Medicare expenditures after the 24-month waiting period. Take a closer look at this. And reductions in Medicare costs may also substantially offset the cost of providing the AD health benefits package. The final research area we're going to look at are the long-term impacts on employment and benefits paid. As Chuck had mentioned, we didn't expect big impacts on employment 1 year following enrollment, but we did expect them to materialize in the longer term. Chuck also showed that there was an impact on increased use of employment services within that 1 year, and we're hoping that that increased use of employment services will translate to employment in the longer run. Our early data, as Chuck showed an increase in use of employment-related services. We have the opportunity to use our administrative records to examine whether there are increases in employment and reductions in benefits paid in the long run. And these increases may offset some of the costs of providing the AD benefits. So to summarize, what we've learned so far is that AD has provided SSA with extensive information to guide program and policy decisions. And although the cost of the health benefit package was as substantial as Chuck showed, we believe that there are some areas here where we can offset some of the costs of the AD health benefits package, and there might be some potential places for some savings. The short-term outcomes that Chuck showed are promising, but we really need to continue to evaluate long-term outcomes to fully estimate the benefits of the AD health benefits package and to provide policymakers with the information that they need to make decisions about altering the 24-month waiting period or altering the health care reform legislation. Thank you.
Well, let me start off by apologizing to Chuck. We're so late that the little bars for all of our graphics were on spring break too. So we have a little over 25 minutes for Q&A. So first question, Steve. Yep, we have a mic coming around.
I'm Steve Bell from Apt Associates. I want to ask you, Bob, are there plans to do a social benefit cost analysis of this intervention, and particularly one that would take account of improved quality of life and longevity?
Yeah, I think the first steps that we wanted to take a look at were what were the impacts that we're seeing on health and mortality in the longer term, as well as Medicare and Medicaid usage and our benefits, and then depending on what we see there, if it looks like it's worthwhile to do a full social benefits and cost analysis, that we would actually do that. But what we want to do is take a look at what we're finding first and then make a decision as to whether it made sense to really do that in the long run.
Bernie Wixon with SSA. One of the things that we did in looking at some disability research was to look at how survey respondents responded to the general health question. And we looked, and I recall one of the things that initially we had to find explanations for was that a fairly high percentage of DI beneficiaries characterized their general health as good, very good, or excellent. And we eventually concluded that even though they had very severe impairments, that they were not, at the point they were answering that question, they were not in crisis. They were not, their health had stabilized and so on and so forth. Maybe it was people with deafness or blindness or people who had fully recovered from heart attack or were in remission or something. And what this makes me think about is that, you know, some of your group may really have beneficial responses to your demo in terms of their health outcomes, but another group, subgroup, may be the people for whom the employment incentives work. And it may be that it might be worthwhile to look very carefully at, you know, the differences between those groups in terms of are they at a stable or equilibrium point such that employment could conceivably work. And I just wanted to suggest that as a way to sort of focus your analyses and figure out what good strategies would be for, you know, early intervention.
I just want to say too, we did in our first year assessment compare, I believe, impacts for people who said their health was poor, worse versus others, and I think the samples are just small enough that we couldn't really see striking things going on in that comparison. In our in AB, about a third said their health was good or better at baseline, so that's surprised us too, but it's consistent with what you're saying.
All right, the first question here is from Sabrina Edgington. In the control group, do you know where they were getting their regular sources of care, community health centers?
Yeah. Dave and I were debating whether, which one of us should answer. The answer is no. But we just didn't, again, for the control group, the information we have on their healthcare is from a survey, and, we asked a lot of questions, but there's a limit to what you can ask in a survey, and I don't believe we asked about whether they were using a clinic or what the actual source of care was, but maybe Lisa looks like she, we did?
Yeah, well, we had some for emergency room. We did have emergency room as the usual source of care, and that actually was a fairly substantial, it was larger at baseline, or at follow-up than I think we might have expected. But I don't think we know all the different sources.
Yeah. But the emergency room wouldn't have been a usual source for a lot of people because only about a third ever used the emergency room.
So the follow-up question, if people did have a usual source of care, allowed them to identify whether or not it was sort of internist, general practitioner, a specialist, a clinic, et cetera. So there's a little more data that we could dig into.
But we don't know the answer.
And we don't know where. We know who, but not where. Yeah, that's true.
Hernam Singh, associate. I know David said that the people in this study whose disability was adjudicated pretty quick. So is there a difference between, because a lot of them get adjudicated pretty late. So is there, when we're going to generalize this study to other populations, did you look at the differences between that group and the group which was in this study?
Yes, we did. Actually, we looked at it in a couple different ways. First, we looked at the population that SSA gave us that were more quickly adjudicated, and a clear difference between that group and your more typical new awardee is that group included a substantially higher portion of people with cancer. But a lot of those people in that sample eventually screened out because a lot of people with cancer actually have health insurance, so a much smaller portion of our population have cancer. So in answer to your question, we did analyze how, in the report includes a summary of how our population differs from the general SSDI population. And I think as you heard Bernie talk about, one of the key differences is that the self-reported health measure, even though we don't have one for the overall population as comparison, I suspect our population would report much worse health and much more severe health outcomes.
Let me briefly follow up on that. You, David, had a statistic on the percent with obesity, right? It's 40+%. Yeah. And Bob, you mentioned that number too, but that was just for your sample. I was wondering if there's probably no number like that for all beneficiaries, right? Not all new beneficiaries.
I'm thinking our mom and I think Ann had done some work looking at people who come onto the program and report obesity as either a primary or secondary condition. They kind of get a handle on that. But that's not the same as looking at self-reported BMI. And it's probably a much smaller group because many people probably come onto the program and don't report obesity to us. Yeah.
Other thing I was wondering is whether we think our sample was more likely to be insured than other UBI beneficiaries, because we found about 14%, but in rereading the report last night, our introduction says 1 out of 5 new beneficiaries are uninsured, so maybe because they're less healthy, they're more likely to have insurance.
And also the measure of obesity that was used as a primary or secondary impairment to get our benefit is much higher than 30. It's almost 100% more than your regular weight should be. So the measure is going to be completely different.
Just to pick up on what Chuck was saying, we also, one of the things that makes it difficult to compare is that we also are looking at a different age group and a number of other differences between what you see in previous studies and what we see in PRAPE.
This next question comes from Emily Carmody from the North Carolina Coalition to End Homelessness, and she asks, was the medical case management and benefit counseling all done over the phone? And is there any literature about the results of phone versus in-person medical case management?
It was all done over the phone. I'm not sure about the literature. It's hard to really address questions about medical case management, and for the reason that what we call medical case management in AD wasn't what I think the rest of the world would think of as medical case management, with much lower level of intensity. And so I'm not sure how to respond to that. I know there's certainly a huge literature that says that care management delivered by telephone for specific conditions like depression is certainly effective in certain circumstances, but I haven't seen anything that compares phone head-to-head with in-person.
Yeah, I haven't either, but I think you've identified the key difference between our intervention, which was serving a broad population with different impairments, versus the typical disease management interventions, which take on a much more narrow, and they have structured protocols for dealing with disease management issues. They tend to be specific diseases like diabetes.
I'm Kathy Ruffin from the Center on Budget and Policy Priorities. From looking at the graphs, it appears that about 5% of the people in our 3 groups died within the first year of the start of the program. To what extent were they skewing your figure on per capita health costs, and did a lot of them, in fact, hit your $100,000 limit?
I don't actually know the specific answer. I do know that people were much more likely to die if they came into the study with neoplasms of the cancer, and that group used about $30,000 in the first year in care. They actually was even more than that. They used 2 to 3 times as much care as the average person in the sample. So it's clearly the case that that group is both more likely to die and would need even more care. But I don't think we did that specific analysis that you were.
Michelle Stegman and I did actually look at the people who hit the $100,000 cap and see what percentage of them died, and I think the number was about 24%. So about a quarter of the 100 people who hit the $100,000 maximum actually died within the 2 years following enrollment.
All right, the next question from the webinar here comes from Corinne Dietrich from Abilities in Motion, and she asks, how long will this study continue to compare the long-term outcomes?
We're going to continue to follow the AB sample for the next couple of years at a minimum. We sort of have a plan here to first take a look at health and mortality, then we'll look at Medicaid expenditures, and then longer from now we'll look at Medicare expenditures, but we'll continue to track employment outcomes for the next several years to see whether we're seeing impacts.
I was looking at Chet's graph, and then you look at unmet health and unmet medicine, and you will think medicine will be nested in health. And then you look at the control group, it seems like it's a little bit higher than unmet health. So I want to know what questions you were asking to figure this out.
I see Lisa looking at something for you guys, Lisa Schwartz. They were asked, my recollection, but Lisa should have a probably that they were asked sort of a general question first about any unmet needs, and then they were asked more specific questions. So I could imagine somebody, after that sequence, that somebody might not have indicated to the general question they had an unmet need, but then when they were asked very more specific questions, they realized in answering that they did, and that could be why you would have had a higher rate for the prescription medications than overall. I agree, you're not really logically consistent. I don't have the survey in front of me, though, to know exactly how the questions were asked.
This is Lisa Schwartz. I don't have the survey in front of me either, but from what I recall, we asked a series of questions about whether or not people had been referred to a specialist and whether or not they had kept that appointment and why not, whether or not they'd been referred for tests, et cetera. So that was sort of the battery rather than sort of a general, were there any unmet needs that you didn't meet? There wasn't that kind of a general question. It was more specific. And then a series of questions about prescription medicines and whether or not people took them as they were intended to. And if not, why not? So those were questions along the lines of, I think Chuck, you mentioned this, whether or not they had ever reduced the dosage they were supposed to take, taken it less often than they were supposed to, and why not? So that was sort of the battery of questions on that healthcare.
A lot of potential policy applications from this work, and more to come, I'm sure. To that end, has the study team checked how well the 53 sites represent the nation? What share of the nation's beneficiaries are in those sites, and that the rest of the country is different on important factors?
Yeah, I think we early on, and we know the 53 were chosen, I'm sure Dave mentioned, because they were the biggest. We were trying to get the sample in as quickly as possible. They were the 53 with the most new DI beneficiaries. So I think they ended up representing about half of new beneficiaries, but I don't know how they compared another.
I think you're right. I think actually it was more than half. I thought it was more than half, and so they would be more likely to be in urban centers relative to more rural populations. So I suspect that there's going to be some differences in terms of one of the goals of the study. It wasn't necessarily to be nationally representative of the entire population, particularly given the select nature of the group that was served, but rather it was to be national in scope, to have a distribution across the country. So this is a long way of answering your question. We haven't done the detailed analysis of how it compares to the overall population, but we do know how they compare to the general population of new awardees.
But it does one thing to be cautious about is that a lot of these cities have pretty substantial healthcare resources. So maybe the DI beneficiaries in smaller places would have access to healthcare that could mean these aren't generalizable. We never really looked at that. It would be interesting, but even within the 53 sites we looked at to kind of try to tease out what the relationship between local site factors and an impact.
I see Bob nodding. I think that would be a good investment, would be to investigate that a bit.
I think you're right on point, and one of the things that we can do is look at our Medicare and Medicaid administrative records to see what kind of, because we start off with everybody, and we have information on everybody, and then we cut it down to the 53 sites, and we can take a look at differences using the administrative data between the two groups to see, and especially looking at the control group here, to see how the control group differed in terms of Medicaid usage and Medicare utilization compared to the group in the other areas that we couldn't select.
I'm just looking for a comment on the PGAP portion. I'm thinking about our TNF-SSI population versus this population. And our population is much younger, and so they probably haven't had the opportunity to have a very extensive work history whatsoever. Plus, they're in a program that requires work and requires that they have a dependent child. So it's mostly female and it's young. Did you look at the characteristics of the population that didn't take up TGAP? You know, just so that I would have some comparison. I could make some comparison with what we're looking at with this project.
I'm answering these questions first because I'm holding the microphone, but we didn't do, I don't think we did that civic analysis, like look at people who didn't take it up and what are their characteristics. We do know there were some differences. You know, people who were less healthy were less likely to use PGAP. People with cancer were less, a lot less likely to use PGAP, but we didn't do the specific analysis that you're talking about. That would be interesting to do.
This next question is from Joanne Schneider on the webinar. She's wondering about the employment outcomes for the AB plus population. Could you please expand on the types of jobs found, the percentage of those who found work, and the challenges found in finding work?
Yes, the employment impacts were negligible. Insignificant is probably the precise term. As I recall, I believe the overall employment rates were between 5 and 10% across all three groups. We did see a little bit of a trending up for the AB plus group and looking for work, but it was not a significant impact. And so I think that the book on employment still needs to be written, particularly given how small the employment effects are. It's hard to say exactly where they're going and whether there's a substantial trend there. I think that we're dealing more with a population that needed medical stabilization first and was thinking about employment second. I think there's something in the report, but I do not recall off the top of my head.
There wasn't much 1 year out, but there are things that we can do with our administrative records. We do have information to look over the long term about their annual earnings, and when we investigate those annual earnings, we sometimes obtain information about who their employer is, so that we can take a look at the earnings that people who return to employment have, and to a limited extent, the types of jobs that they're at least reporting to us, so that we can put together kind of a profile here of what kind of employment outcomes we're seeing in the longer run.
And the Department survey did have some questions on the types of jobs that they wanted to analyze those. We didn't include them in the report because it was supposed to be about the effects of AB and AB plus, and there weren't effects on employment, so we didn't look at the types of jobs for the report. Recruitment was 2007 to 2008, and so folks are in for up to 2 years after that. The last person came out in the end of last year.
Yeah. They're coming out right when the economy is picking up.
Our chair with the National Institute on Disability and Rehabilitation Research as part of OSERS and the Department of Education. I wonder if you looked at other resources that these people might apply to, such as the state VR programs.
Yes, our employment services questions from the survey included a battery of those types of questions. And as Chuck mentioned, there was a significant impact on employment services amongst the AD Plus group, and that impact was really concentrated in the ticket to work, in the use of ticket to work services. We looked at other components, but the effect sizes were so small. I believe, and Lisa, correct me if I'm wrong, we have ticket, VR, one-stops, and education was, whether they were continuing education.
This last question comes from Jeffrey Peterson from the Legal Center for People with Disabilities and Older People. Did you get any data on individuals with traumatic brain injury? It is commonly believed that the earlier a TBI survivor gets medical and therapeutic services, the better the outcome. Were you able to support this perception?
We just had, really in the end, we looked at some things by impairment, but there were just too few people in the study for any particular impairment to say anything about whether it was effective for, one group versus another. So it's a really interesting question, but we couldn't address it through the study.
Okay, well, we're just about out of time. Let me tell you about the next forum, which, before we go, it's scheduled for June the 8th. The title of it is Federal Spending for People with Disabilities, Continuing Society's Commitment While Reducing the Deficit. Gina Livermore and Andrew Houghtonville and myself are going to present some new statistics on expenditures to support working-age people with disabilities, and also the numbers and characteristics of people who are receiving those benefits. And Andy Imparato from the Senate Health Committee's staff for Senator Harkin will be here to comment on policy implications. So I hope some of you come back for that, and it's not summer vacation yet, so maybe we'll have a good crowd.